start with the Oh, sorry. I'm going to start with the introductions. Yeah, and whoever is just joining in, they can keep joining in. But yeah, I'm going to start with the introducing the event. So, hi guys. My name is Ioana Marmerstein. I'm an event coordinator for the pre-med community at UCLA. Hold on, I'm going to just turn off the notification bell. Give me 1 second, sorry. Or actually, can one of the other schools do that while I introduce? Sorry, thank you. But yeah, so my name is Ioana Marmerstein. I'm an event coordinator with UCLA, and we plan this event with UCSB, Columbia, Berkeley, and Harvard. Just a collective event with other pre-med community clubs at the school, at each school. So we wanted to plan this event because it's something similar that we did last year. We had just a general like health summit with panelists of different physicians, and a lot of students found it to be beneficial to ask their questions. And so we thought that we'd plan it again this year. So that's why you guys are all here. And thank you for the physicians for showing up, and thank you for all the students for coming as well. Hopefully you guys will be able to benefit from this. But basically I will just describe the structure of the event real quick. So the first half, the first hour is going to be each school's representative is going to be asking general questions, and all the physicians will just take turns answering. And then the second half, which is the second hour of this event, will be individual breakout rooms. So you'll see that if you look at the breakout room feature, each breakout room has labeled with different names, and also our Princeton Review rep too, because she's going to be just giving some information in her breakout room as well. So once the second hour hits, we'll tell you when to join your breakout rooms. But for now, we're all going to be in the general room for now. And so the first half of the event, we're going to be asking specific questions. But then the second half, if you guys have your own individual questions, feel free to just write them down, save it for later, and then you can go into the breakout rooms in the second half and answer them. So yeah, I'm going to pass it along to I believe UCSB for the introduction of the physicians. Thank you.
Yeah, so before I introduce the physicians to everyone, as was mentioned, we also have Joan here today from the Princeton Review, and she's going to speak about the medical school application timeline. So if you think that this talk would be helpful for you to listen in, please join her breakout room in the second part of this event. And now I'd like to start introducing the physicians who are joining us today. And first off, we have Dr. Antony Rugger, who is in oncology, and Dr. Ioana Pasca, who is in anesthesiology.
Hi, everyone. I'll be introducing the next set of speakers, who is Dr. Dominguez, who specializes in psychiatry, Dr. Mirbaha, who's a neuropathologist, and Dr. Hui, who is specializing in internal medicine.
All right, so I guess we're going to start with the first question then?
Yes.
Everyone okay with that? Okay, perfect.
Yes. Hi, I'm Yasmin. I'm representing UC Berkeley along with Isabel. And just to start off, we'd like to know, why did you decide to become a physician, and how did you know it was the right career for you? Whoever wants to get started with that, go right ahead, please. Thank you.
I guess I'll go first. I didn't know it was a right career for me, actually. When I started out doing law. So I grew up in England. I went to law school, qualified as a lawyer to begin with, and then realized that wasn't the life for me. It didn't have the end results, I think, and the sense of worth that I thought I would get out of it. So then I went back and did some pre-med work and went back to med school in the US. And I think the reason I went into it is a love of science. So it's the applicability of science to the real world, right? So you're seeing patients right in front of you, and you're applying new breakthroughs in your field in real time. And then it also used a lot of my social skills, I think, communicating with people and being able to talk to people and work through a point in their life when they had a major event going on and help guiding them through that. And then you see the end result of your work. Like when I was a lawyer, we were working in big firms and you're just sort of a cog in a wheel. You don't really see the end result of what you're doing. And I think with a doctor-patient relationship, you see sort of the process and how things are going. And so that's kind of the thing that drew me, the science, the social aspects, and the tangible vision of the end result of what I was doing.
I'm going to jump in next. I think it's an excellent question, and it's a really tough question. Excellent and tough, because I think my answer echoes Dr. Ruggeri's answer. I really love science. I was fascinated by the puzzles. I still am reading physics, just trust me. It's strange, I understand, but I love keeping up with it because it's just critical thinking and cutting edge information is so, I find it incredibly fascinating. And I think that the applicability, I went into psychiatry partly because I love talking, I love people, and I love connecting with people and communicating to people. And I think I will give you a microscopic anecdote. I was on the subway in Manhattan one day, years after my residency, and this woman came up to me and said, "Thank you so much. You saved my sister's life. She's never tried to kill herself again after that one time you saw her at 3 o'clock in the morning in the emergency room." I didn't remember her. I didn't remember the sister, because you see so many people, right? But you can make such a big difference in one person's life and in that entire family's life and that community, that I just felt that it was the right fit for me. And the other thing is that in medicine, you could be a teacher, you could be a researcher, you could be a professor, you could be a family practitioner, you could do public health. There's so many things you can do that it just gives you a lot of flexibility.
I would echo most of what has been said. I think that I was a chemistry major at UCLA, and my initial idea was to find a new drug, from the Chinese herbal pharmacopoeia. And as a foreign student, I was not thinking that it would be easy for me to get into a medical school, but I did, But then 1971 was a major. Actually, I've been at UCLA since 1968, 69, and I started medical school in 1971. So been 50 some years that I've been at UCLA, and the way to think about getting into the medical profession is that there's so many things that you can do, and now not just medicine. Think about big health. The idea about so many aspects that you can use this rigorous training to allow you to kind of contribute to society in numerous ways, not just being a one-on-one patient and doctor. So I have changed my career within medicine over the last 5 decades, from being a bench researcher to a clinical researcher to a primary care doctor to a consultant in the hospital, to be kind of the last 28 years build a new discipline of integrated medicine, blending the best of Chinese and also conventional medicine. And now, I'm more interested in how do you implement this? How do you basically, learn from the people in business, people in technology, people in media. So I think it's important for you to have the right purpose and want to get into the healthcare field. And as a physician, I mean, you have this privilege that nobody would have, because people really entrust their life to you. And I think this is also both an important sort of component of why we choose this profession, but there's all a responsibility. So unless you really, really, really want to go into medicine as a physician, but you can also do many other things, without really working with one person, because that person entrusts their life to you, and you better really don't make too many mistakes.
Hi everyone. Since no one else volunteered to continue answering this question, I will just jump in. Yeah, that's a very good question. So I grew up in Iran. So there, the education system is like when you're in high school, you need to decide what field you are going to go after graduation from high school. So we start the medical school right after high school. So I didn't have this undergrad period to decide. So I was really enjoying the biology during high school, and being one of the top students in the school, everyone was just persuading me to medical school. So it was a natural thing to do rather than just being an active decision maker. When I started medical school, I really enjoyed everything in the science of the human health. But then by time I realized there is no specific specialty that I am pretty sure that is very significantly different from others for me, that I'm pretty sure that I'm going to go. Instead, I'm really enjoying the basic science of the human body. So I decided to spend a few years on research and to discover myself more, since I didn't do that before medical school. So after graduation, I did a few years of research, and I realized, wow, that's exactly what I love to do every day. And so I joined a lab to do a very kind of more professional way of doing research. And I spent some years in it, and that was, I think, the best decision, because during those years, I realized I'm really enjoying doing research, but I miss being part of the patient care. So it was not a wrong decision to go to medical school, but maybe I did not have interaction with the exact same thing that I want to do. And that was pathology. So I interacted with pathologists in my research, and I realized, yep, that is what I want to do. So I just want to look at the tissue under microscope and being part of the healthcare by making the diagnosis, and also being involved in research. As colleagues mentioned, you have this opportunity in medical field to be part of education, research, and healthcare. I decided to do my residency in pathology, followed by my fellowship in neuropathology. And here I am.
Thank you all so much for your responses and your insight. My name is Ramya. I'm from the UCLA pre-med community. Our second question to you all is, how do you maintain a healthy work-life balance? And what do you suggest for students who are also on this pre-med track?
If you find the answer to that, let me know. I'm still working on that even to this day. I don't know. I mean, I think hopefully things will change for your generation. It was very toxic in our day, right? I mean, it just was residency and med school. I just, looking back, I don't know how we did it really, but you're all in it together. You just do it. That's what everyone's doing, and you sort of get through it somehow. But I think you have to make time, right? And you have to do the things that are important to you. You know, if you want to have a family and spend time with them, you have to make that clear to your employer that that is of utmost value, and don't let them push you around. There's this sort of tendency that if I'm not always there achieving and doing everything and being everything to everyone, I'm somehow some kind of a loser. And it's just not true, right? You have to make space for your life. And it's not easy though, because you start saying no to a lot of people. They don't offer you things anymore. So you just have to kind of come up with a solution to that. Like recently in life, I'm now like, if I don't really want to do it, then I'm going to say no. You know, whereas when I was starting out, you kind of have to say yes to a lot of things just to get your foot in the door. So it changes depending on the point you are at in your career and what you still need to achieve. But you need to do that to avoid burnout. Burnout is so huge in medicine right now, and you've got to figure that out somehow. That's a great question, which I don't have a simple answer to. Hopefully the others do.
I'm willing to jump in again. Okay, so I think you have to play. Number one, you have to play. You can play an instrument, you can play games, you can play Dungeons and Dragons, you can crochet, I don't care what you do. You can bake, you have to do something else. that because what a person with only one, bandwidth is, that's a problem, because if you lose that bandwidth, you have nothing, right? And that's part of what happens. If you throw yourself in and you work 700 hours a week, I don't even know if that exists, but you guys work really, really hard. And I just figured out that I was working a 60-hour work week for about 30 years. And now I'm working a 30-hour work week, 35 hours, and it feels like a vacation. And that's what most people work, right? A 40-hour work week. That's like what we're supposed to be working. But I think that, what Dr. Ruggieri again said is it varies throughout your career. At the beginning, you do have to put in more time. And you really, to me, one of the important things is to make connections with mentors, with colleagues, your friends. You're in medical school with people, and those people become you're like in a war, right? You're like, they're your anti-PTSD people. They're like your buddies that you go have fun with. When I was in medical school, we would take time to go to the museums. We would go dancing. We would go, there were all kinds of other things that people did that you have to make time for. I have a friend who played the violin and danced throughout medical school because it kept her sane, right? So I think you use your hobbies that you love, and you also expand and learn new things. The other thing I would say is I think that science is very left brain. And I think it's really important to use your right brain and do artistic things because it balances you. I think that's it. That's good enough.
Well, I really don't have much to share, except that now, working at 40 hours is like semi-retirement. But, in our days, it's like, 120 hours a week. And and also actually during my internship, fourth year, I already have my first baby, and then I have twins, and I'm expected to have 3 babies during internship. So,
wow.
So that would be very difficult to find work-life type of balance. But I think, there has to be some sacrifices. Like one of the things about, getting into medicine and trying to do something impactful. But again, as I said, you need to basically have that motivation, that passion, that drive that you want to do something exciting, impactful in healthcare, in medicine. And that would, otherwise, if you do not have that, and I can see that a lot of people really, would have trouble going through, the rigors of the first 10 years in your medical career, and it will just continue. Depends on whether you go into medical practice versus research. Research is a lot of grants and a lot of there's always money problems. Okay, whether it's social but also in the academic and the clinical practice. So I think but again, you have to have some time for yourself, and I right now teach a lot of people who are in a lot of strain, to learn how to get, some self-massage, meditation. And sometimes, you do not need to spend a whole lot of time. You just need to keep yourself, even within an hour, just 1 minute, you will be able to help cool your system down, and a lot of people basically do not know how to stop. And that's what, get them into trouble, is that you need to pace yourself.
Yeah, thank you all. I also don't have much to add. I'm still in training, so I still need to spend a lot of time to study, learn. But I've decided to just stop thinking about work and everything at least 1 day a week. So I do not check my work email, do not check my work phone, everything for just 1 day, and just get everything free. But I'm not sure how long I can sustain that, but so far it has worked.
Well, thank you so much for your awesome answers. My name is Lucas, and I'm a representative from UCSB. And our next question is, why and how did you choose your certain specialty in medicine?
So I guess we keep the answering order. Mine came during med school and residency. I didn't know from the get, I'm an oncologist. And so I didn't know from the beginning that I wanted to go into oncology. I think when you're doing your clinicals, you'd be sort of in the emergency room or on wards rounding and things, and you just start to gravitate towards a certain type of patient. I think I found myself in the emergency room, and rather than the person with a diabetic problem, I was sort of spending more time with the patient who's has cancer, and it just seemed to be something I naturally gravitated towards. And I think it's part of your personality, right? So I think for me, there was so much going on when someone told they had cancer. It's such a massive diagnosis, and I felt that that really tapped into something in me that I wanted to reach out and sort of help and be part of that person's journey somehow. So I think it's the social aspect of that. There's some part psychologist, part social worker. Plus at that time, oncology was, and still is, you know, really moving forward. And I had this sort of feeling in my mind that we were going to make some huge breakthroughs and really start to crack away at cancer, and I think we have, and I think we will in your lifetimes too. So scientifically, it's very challenging, very interesting. Barely a week goes by that we haven't got some new drug, some new class of drug, even immunotherapy, targeted therapy, CAR T, CRISPR. So I mean, it's just keeps you really on the cutting edge of science, but it taps into all your humanism as well. And I think it just did it for me, but I think there's many answers to that question as there are doctors, you know.
Okay, I'm up. Okay, so you know what? I was a psychology major as an undergrad, but I wasn't planning to be a psychiatrist. But I think, again, what Dr. Ruggieri said is you get drawn to certain areas while you're doing your rotations. I mean, some people go into medical school and they know they want to be an ophthalmologist, or they know they want to be an orthopedic surgeon. And either they've already talked to them or have had contact with them, because otherwise, how would you know, right? How would you know that that's exactly what you want to be, unless it's a doctor that you've had contact with, right? And in a specialty. But for most people, it is in your third year. Your third year is when, and maybe in some places, it actually starts in your second year. You have patient contact and you start your clinical rotations. And as you do that, I mean, the other opportunity is to shadow some doctors now, earlier on, while you're still in your pre-medical phase, and get to know, a little bit, get a little like a buffet, right, of different areas of specialty. I was in medical school. I finished in 1986 and I finished residency in 1990. And managed care was becoming a thing when I was in medical school. And one of the things I realized is that I like to talk to people, and that it was to me, it was very difficult to know how I was going to, doctors tell you, lose weight, exercise more, eat a different diet, take away your salt. And if you could say whatever you want, nobody's going to listen to you, right? If you have like a one sentence, you say, you're not going to talk them into anything. And so for me, I felt that having a longer session, a longer visit with a person would really let me help them in bigger ways. And also in terms of their family, right? I see things, the patient is one person in a community and in a family. And so by helping that person, you're actually helping a broader group of people. The other thing is I just loved, I loved psychiatric illness, right? People are depressed and they get better. 4 to 6 weeks later, they're like back to themselves again, right? And anxiety. And now, referring to Dr. Hui, is it Dr. Hui? How do you Hui? Dr. Hui, integrative techniques, right? Breathing, meditation, mindfulness for anxiety. There's a million things, cognitive behavioral therapy, dialectical behavioral therapy, the psychopharmacology that we're coming up with. Naltrexone, right? Naltrexone for drinking to decrease the craving for alcohol. The brain, this is not exactly psychiatry, it's kind of neurology, but they're using Zyrtec for brain fog that's COVID related, right? So all of these interesting and different things that are coming out in neuroscience and in psychiatry and neurology, I think I was fascinated But I have to tell you, I was tempted to do family practice and I was tempted to do pediatrics, right? And so at the end of the day, psychiatry won. But I think if you're, if you fall in love with things, you're going to find something that you fall in love with, right? And that's basically hopefully what your career will be.
Well, my whole career is shaped by my interest during first, second year medical school that I want to build a better healthcare model by blending the best of Chinese and Western medicine. So I picked internal medicine because it's very comprehensive, it's pathophysiological driven. And then I subspecialize in clinical pharmacology because I see that we have many diagnoses, not enough treatment, and then the drugs are just, so many problems. So that's why I taught internal medicine and clinical pharmacology for 13 years, while I was trying to understand how to put the Chinese medicine by incorporating into global healthcare. So that's, then I get into preventive medicine, occupational medicine, because really you have to basically try to keep moving. As I said, I mean, a lot of people actually in the old days just practice one area and then they go to retirement. But I think in your generation, you have to be very flexible to keep moving and learning, and doubling time for health, scientific and medical information is 73 days. So you have to really figure out what would make you tick, what at that point in life. So for me, I picked internal medicine, but I keep moving. I basically, once I master one area, I move to another area. So I inject endorphin into man. I work in psychiatry area with depression. I get into diabetes and heart failure, hypertension, thyroid, and pain. So realistically, and then I get into cancer as well. So there are just different ways for you to get yourself, stimulated, in wanting to learn, and through learning and helping people and learning. So, but I started with internal medicine after, medical school, but I have, kind of get into many different other areas afterwards.
So I think I kind of mentioned in my previous story. So yeah, I did not have much interaction with pathology during my medical school, besides just one semester that we had pathology course. And it was mostly just reading through the books and just looking at sample slides. I was not involved in a pathologist's daily life to know what they actually do. So it was not an option for me. Later on during my research, I interacted with neuropathologists a lot. Oh, actually, I forgot to mention that since I started my medical school, I started realizing how much I'm fascinated by everything related to the brain, like neuroscience, neuroradiology, cognitive neuroscience. They were all really made me excited to read about and learn about. But I still was not there yet. So during my research, I interacted with neuropathologists and I just learned what they do and what is their daily life like. And then I started realizing that's exactly what I was missing so far, not knowing that such a thing exists. And yeah, that was the reason I chose this specialty and followed by this fellowship.
Hi, thank you so much for answering all of our questions so far. Our next question is, what does a typical day in your life look like?
I'm just going to add one last thing to the last question too. As others were talking, I thought about this. Don't follow the money and don't follow whoever's the most popular person on the. Every generation has a medical TV show, and whoever's popular on there, if it's ER or something, everybody wants to be an ER doc all of a sudden. So don't follow that. Don't follow the money. You're all really smart people. The other thing is, don't try to get into the most competitive specialty. You obviously are the brightest of the bright, and you could get into anything. And there's this tendency, I've always got A's, I've always striven to be the best. Therefore, I'm going to try to get into whatever may be the hardest subspecialty of your time. but that changes all the time. You know, it's very easy. 1 minute, I had no idea what oncologists made as far as money goes or anything like that. So you go into it because you get a reward from it and you love it. So just avoid that trap, and I'm sure you all will. That doesn't probably need to be said. Anyway, a typical day for me. So I'll just go through tomorrow, basically. So medicine is now a team's oncology anyway. It's kind of a team sport. It's much less individual based. We have a group of doctors who sort of help come to decisions because everything is moving so quickly. So I do GI and GU oncology, which is gastrointestinal organs and genitourinary organs. So tomorrow, so I get up in the morning, make a cup of coffee, take a coffee up to my wife, walk the dog and all the rest of it like we all do. And then I go to my first meeting of the day, which is from 7 to 8, which thank goodness nowadays they're on Zoom. We used to actually have to be in the hospital in a big room altogether, but now we do them on Zoom. So that will be a GU multidisciplinary conference. And there'll be other medical oncologists like me. There'll be radiation oncologists there. There'll be urologists and surgeons. There'll be research people. There'll be integrative care people, radiologists, pathologists. And so new cases that have come up recently or any other challenging case that you've been following, you can request to be put on there. So we try to present all the new cases that came in the past week, plus any new challenging cases. And then you'll present, you'll give a little history. This is Mr. Brown. He's 64 years old. He's had some blood from his urine. He's been diagnosed with bladder cancer. And then the radiologist will show you the imaging and the pathologist will go through the pathology slides with you. And then you'll sort of put your heads together. How will he benefit most? Do we use chemotherapy? Do we use immune checkpoint therapy? Do we use radiation? Do we use surgery? And we come up with a plan for that patient. So that is 7 to 8 tomorrow morning. And then 8:30 till noon, I have patients. So then I have to prepare for that the day before, usually, because nowadays medicine is moving so quickly. I need to have reviewed everybody's scans the night before and kind of know where they're at and what's going to happen next. So then I go through the morning meeting people and telling them how they're doing and what we're going to do today and what the future might hold. And they have their questions for me and whatnot. Then I have a GI MDC tomorrow. So that's noon till 1, same thing as I had from 7 to 8 for the GU. And that one's actually a clinic where patients can actually come into the hospital and they get seen by all the specialties. So it's sort of a one-stop shopping for them. So in the old days, the patient would ping pong from doctor's office to doctor's office, but now they come into the hospital and then we kind of see them in turn. So we discuss their cases from 12 to 1, 1 to 2, we would go and see them. So then I would go in and say, you know, you're going to go through a surgery, and then after that, you're going to have 3 months of chemo. And so we sort of describe to them, and then if they need to see radiation, they'll see radiation. So then we do that. So that's 12 till 2. Then 2 till 5, I have patients. Actually, it's not 2 till 5 tomorrow. It's about 2 till 4. And then I'm interviewing fellows. So there's new fellows coming into our program. So tomorrow's a fellowship interview process, and I'll interview the fellows. Then I'll go over to the hospital and see anybody who's in the hospital of mine. So if I have patients who've been admitted, I'll go by and see them in the hospital, see how they're doing and see what they need. Luckily, we have doctors in the hospital who take care of our patients while they're there, but then I would round on them as well, and just to see what was coming up from an oncology perspective and see they were being taken care of and if they had any questions for me or anything like that. And then I would go home. And then this is the sad part of medicine, which I hope you guys can fix, because then the rest of the evening, I'll be doing my documentation. You know, I'll be catching up on all the things that are inside my electronic medical record. So documenting notes that I didn't finish during the day, putting any orders in that weren't completed during the day and that kind of thing. And then that's my day, really. I eat dinner and have a chat with my wife and go to bed.
Pretty good. That was pretty amazing. Okay, so what you described is how I lived my life until last December. So, but I've been recycled in a number of different roles. For many years, I was the director of psychiatry at a satellite hospital for New York Presbyterian at the Allen Hospital. So I was in charge of an inpatient unit, the emergency room coverage for psychiatry, and a consult liaison service, which is basically when the psychiatrists see the patients that are medically admitted. So my day at that point would have been rounds in the morning. For the inpatient unit, you basically we got together at 9. Many inpatient units start really at 8 a.m. And you spend about an hour talking about every case and what's happened in the last 24 hours. The nurses usually do the report on who's where, who's doing what. A lot of what happens in psychiatry is when the inpatient unit that I was working with, there are a lot of patients who had substance use problems and psychiatric problems. And they were, we were in an underserved, impoverished community. And so there were a lot of difficulties that we were dealing with. We did, following the rounds, we would have team meeting. Team meeting was basically a smaller group of people, a multidisciplinary group with the social workers and the substance abuse counselors and the nurses, occupational recreational therapy. And we would talk about each case, each team. We separated it up so it wasn't the entire unit. And essentially that was treatment planning. How better, is this patient better? If they're not better, why are they not better? What else should we be thinking about? Are there any consultations we should be getting? When are we thinking about discharging them? And then planning what their aftercare would be, because you can't just send them out without a plan, and it's not easy to get aftercare for inpatients. Following that, because I was an administrator, I was running the unit, I would have administrative meetings, meeting with the director of the hospital, or meeting with the head of security, or meeting with the social work director. I was also involved with if the patients were being taken to court, because patients in psychiatry can come in as a under voluntary status and involuntary status. I had to make the determination about which cases were going to proceed to court, if we were going to keep somebody when they requested to leave the hospital or not. I had to discuss cases with the hospital attorney. Following that, okay, so that's the first half of the day. And then in the second half of the day, after I would finish my work at the hospital, I would go to my office and see my private patients. And my private patients, some of the private patients were patients that I had taken from the hospital, who I had asked to come to see me privately. A lot of patients with depression, with anxiety, some patients with bipolar disorder. Some patients I saw individually, some were couples, some were, a whole bunch of people in the family unit coming to talk to me about a life problem. And so that's how it ended up being a really long day. The other thing I wanted to tell you about is after I left working at the Allen Hospital, I started working straight consult liaison psychiatry at a different satellite hospital of NYP. And at that point, I was also on the ethics committee of the hospital. So on some days I would be running the ethics committee, which is a whole other thing. And it could be anybody in any profession, any physician, right, could be leading it. But it's a very interesting thing, medical ethics as a separate thing. And that's part of what I'm saying when I was saying that, if you go into medicine, you think you're going into medicine, but you could be an ethicist. You could be, you could be a biomedical engineer. You could be anything, right? So I think I answered your question.
Well, obviously, over the years, you have to learn how to practice, and you do, obviously, I now do not have the burnout like many of my clinicians, but then, you either have to get grants or you have to meet with foundations who may want to support your work. So fundraising is one of the skills that wherever you go, you have to learn that, okay? And that's how I, spend my day. Then I have to, educate the fellows in the clinic and also see some patients. But realistically, I work, this morning too, and I worked last night, working on a WHO, report that I have to provide comments. So in a sense, it depends on the type of career at a point in time in your life. So it will be different. But as I said before, you will go through many areas that would have anything to do with health and healthcare. and that but you if you are a leader, you never stop to have to think about what you would do actually when you have time. Okay, when you just go to sleep and you try to just have a deep sleep, and then you wake up, there will be, and then you think out, you have to think about, well, what else you need to do and so that's why I had to teach people how to leverage. How are you going to delegate? These are the things that really I think are skills that you would have to master.
Okay, so as I mentioned, I'm still in training. So my daily life is like getting up, having breakfast quickly, and going to work around 8. And the first thing I do every day when I get to work is checking the surgery list to know what neurosurgeries are happening on that specific day. And then if there are surgeries that I think they might need pathology diagnosis during the surgery, I would just check the patient's history, check the neuroimaging of the patient, and read the pre-operation exam to know what the neurosurgeon is thinking about, what are the pre-surgery diagnoses. And then I will email the list of these surgeries to our attending so that we are all ready if it happens, because this is something that we need to do very quickly. They call us and they need, when the patient is still under anesthesia and they are in the middle of the surgery, they want to know what is the broad diagnosis, like if it is malignant or benign, if they are in the lesion or not, something like that, not the exact diagnosis, but something broad. So we just need to be there quickly and perform this a study in a few minutes. So mentally, we need to be ready about the patient. I don't have time to check the history when it's happening. So anyways, in the morning, the first thing I do that, and then I start checking. So in the morning, we usually get the immunohistochemistry slides, and these are the special stainings we do for making the diagnosis or guiding us to our specific diagnosis. So I just check the previous cases. I see slides and make the report of them. And then during the day, we get the new cases. So then I look at the slides again and I write as much as I can about each of them. And if there is something that I haven't seen before, I just try to figure it out, study about that case. So it's an active interaction with the case by myself until the afternoon when we sit with our attending and they guide us through the correct way of thinking about the case and how, if I did correctly or not, or how should I have done. So then it's just the active learning process that happens later on during the day. And that is just the, this part of the day happens every day regularly, but we have, as one of our colleagues mentioned, we have some tumor boards, and that's when we present the pathology part of the case, and the clinicians discuss the diagnosis and the treatment options. So that's one of the things that I regularly prepare during the week. I make the list of the patients that I need to have the presentations ready, and that's one of the things. The other thing is once a week we have brain cutting, and that is the autopsy brains the autopsies that have been performed, and the brain is waiting for the neuropath group to be studied. And so we cut the brain. We first examine the brain from outside, and then we cut it, and then we examine the slices. Also just prepare them for microscopy examination. That is also one of the other things we do during the week. And so we routinely have medical students in the morning. Sometimes I sit with them, look at some slides, the cases that we usually get there, in our service. So I go through some of the routine cases with them. And and then once a week also we have consensus conference where we discuss our interesting cases or uncommon cases or cases that I have or we have questioned or with other pathologists. Now we are doing it through Zoom, so more pathologists can join from different cities. So they all join and we just discuss the case. Everyone shares opinions about it. And at the end also they share their interesting cases. So it's very educational and very interesting. Yeah, these are just the routine things that happen during the day. Yeah, I would not say what time I finish and go home because it's not, I mean, I usually finish late. So hopefully, as you mentioned, the next generations would manage that better.
Thank you, doctors, for sharing about your everyday life. I think that gives us a lot of great insight into the different specialties and what they're like. So my name is Leslie Zaragoza, and I'm the External Outreach Director for the Harvard Pre-Medical Society. To transition from focusing on like individual specialties to medicine as a whole, our next question is, what do you think is the biggest challenge in healthcare right now?
That's huge, isn't it? I guess it's how do you deliver quality care to everybody in the United States or within your border or wherever you choose to treat, but everybody, hopefully, at a reasonable cost. And I think that that embodies a lot of problems, right? First, access to healthcare is one of the major problems we have at the moment. Like, whenever you see how much the US spends on healthcare versus any other country in the world, it's just outrageous, right? The bar chart, ours is up here somewhere and the rest of the world is down here. And yet people in the US aren't living longer. When you see who lives the longest, it's, you know, countries like Sweden and whatnot. How come we're putting so much money in healthcare and yet we're not living longer? And then you could sort of say, well, why would that be? You know, what would be the one intervention that you could do that would make people live longer, let's say, if that was your goal? And people sort of think of things like, well, if we get everyone to quit smoking or stop shooting each other or whatever it might be. But I think one of the biggest interventions is perinatal care. Because if you get a child dying a few days of life, that's going to really drag down your national average of life expectancy. And I think that's what's happening in the US. There's so many people that don't have access to healthcare at these critical points. And in a first world country, that's just not acceptable, right? So I think access to healthcare is a massive, massive problem. That's on the user end of it. And then on the provider end of it, how can we provide access to healthcare at a reasonable cost? You know, so you want quality care at a good price. And how do you do that without burning everybody out? Or, you know, we have to wear so many hats as it is. So for my life, I work for a big hospital, a nonprofit hospital, and we call this corporate medicine, you know, and they put a lot of things in our pathway that I don't think are necessarily relevant to me maintaining somebody's health. But I have to do all these things because there's regulations and whatnot. And this creates problems and burnout with the doctors because they're spending so much time spinning their wheels doing things that they don't think they've been trained to do and things they don't think are moving the world towards the goals that they want to be moving towards. So I think it's access to healthcare, bringing down the costs of healthcare, and somehow doing something for the providers so that they can do what they're trained to do and offload a lot of their administrative responsibilities and sort of regulatory responsibilities to somebody else. And I guess just my answer, I guess, because from the last little discussion, I don't want you to be put off by what any one person's work-life balance might be. I don't even like that phrase, work life. Work is part of life, right? It should be work leisure. Work is part of life. And when I go to work, my friends are there. You know, we have these meetings in the morning, we chat and we laugh and we talk about what we did over the weekend. And so it's collegial and friendly. So I'm not begrudging that part of my work at all. And you can also change your job however you want it to be. I have friends who work part-time, people who work purely from home as e-doctors, EICU doctors, and they do everything at home because they have kids or whatever. But I think those would be the things I would say is access, cost, and somehow doing something for the providers.
Yes. That's all. No, I will never only say yes. But yes, no, you know what? Access and cost, right? So look, I would say, so psychiatry, the three professions that I mentioned to you guys, pediatrics, family practice, and psychiatry, are the professions that make the least in medicine. Now, I didn't know that, right? Because we talked about that. I had no idea what people made and what salaries were. That wasn't it. It should have been, I think it should have been entered into my thinking this through, right? Given medical school loans and all of that. But I was living in, I want to do what I enjoy, and I want to help the universe. And so, there are countries in which there are no psychiatrists, that they only have public health nurses that treat the population. There are countries where if somebody has a manic break, they take them and tie them with a chain to a stick in the ground and keep them in a small house or in a garage or in a shack. There are countries, and I've gone on tours, and I presented at the World Psychiatric Association. There's so many places that do not have access at all. And there's places in the United States that don't have access, right? I had a friend who worked for the Public Health Service on Native American reservations, right? There's so many, and I worked my entire career in Washington Heights. So many people who were undocumented, who had no access to healthcare, and so would go without for years and years and years. The patients that I was working with who were homeless were uninsured because they couldn't get it. They could have gotten insurance, but they couldn't get it together to follow through and get the Medicaid that they were eligible for. When the Affordable Care Act came in, I almost wrote a thank you letter to President Obama, because suddenly my patients, so what would happen was we would have homeless, drug abusing, schizophrenic patients come into the hospital, and we would straighten everything out, put them on antipsychotics, feed them, clothe them, clean them up, everything was fine. And then we would let them go, and they didn't have health insurance, so we couldn't get them an appointment. They'd have to go to a walk-in free clinic. The walk-in free clinic, you have to be there at 9 o'clock in the morning, which of course my patients were never going to be there at 9 o'clock in the morning and wait to get an appointment. And then they didn't have any money to pay for their prescriptions. So we would give them a 1-month supply and it would always stop. So after the Affordable Care Act came into play, we had much less of the revolving door that people talk about, that we get people better and then they leave and they get sick again and they come back, because they could go to their appointment and they could take their medication, right? So I think access to care and cost of care is really, really important in the United States, but also globally, right? There are many, many, many places where people are being treated inhumanely and people do not have access to care, to basic medical care, but also psychiatric care. So ditto. And also, but you know what? Again, I agree with Dr. Ruggieri. We'll just let you, run with it. We have to think about ourselves, right? And one of the things that I've been seeing, doctors hate meetings. I will say as a generic thing, we are in so many meetings all the time that we really hate meetings. But if you are not a part of the system, if you don't manage it, then it manages you, right? And so one of the things that happened is, I think that as other organizations and other systems took charge of medicine, then all of these things that are not in our area took charge, and we have to do all these other things that are not in our area of expertise, that is basically a waste of our time, right? And that's where the work-life balance happens and burnout happens, and doctors leave the field because they're like, I don't want to do this. I don't want to spend 4 hours at home on an electronic medical record that doesn't work, right? So that's my answer.
Well, I mean, first of all, I mean, I think that I actually addressed the healthcare crisis, for almost like when we start looking at DRG, back in the 80s. We already recognize that we have an unsustainable healthcare model with aging of society. That's how I also subspecialize in geriatrics and try to, but now I'm moving into family-based adolescent, because I think that unless we really reach kids before they, go through their puberty, because they are going to have so much teen, crisis. So the challenge is multiple. Actually, I just gave a talk about healthcare unsustainability because of the high cost, and that lead to kind of poverty. Half of the bankruptcy is due to even I see the problem now reaching upper middle class. I'm not talking about people really have very little, but even with people with Medicare, with insurance, they are not able to basically support the healthcare that that we are delivering. So it has to be a better healthcare model. That's what I spent my last 30, 40 years to build this model. And now we have been implementing it within UCLA. I hope that it will make it through UCLA Health. But I already moved it to a place like Shanghai. The whole entire Shanghai is get trained 10,000 Western trained physicians to appreciate what this model can do. Because it really is financial instability, and now we have the chronic pain, opiate crisis. We also have the hate crime, the equity, crisis with the mental health crisis to go with it, and then we have the COVID-19, and also the climate. The climate is another crisis that is going to overwhelm the system. So it just need a new health model, which I've been working on, and been talking about, but obviously, and that's why at this point, I have advised some of the pre-meds who has been taking our summer course. You better think seriously whether you want to go into medicine. You can help healthcare without actually going through medical school, residency, and then doing a lot more later on, and then find out that you have a $500,000 debt and not knowing what is going on. And I really think that this is a very, very important question that you all need to look at. I think medicine is a very noble profession. I think it's really exciting with the sciences, with the ability to help people when they are most needed. But that's why at this point I believe that we just not need doctors to deal with the healthcare crisis, but many visionaries, every sector have to come together to address this healthcare crisis. It's not one profession; it's a very complex problem. That I kind of addressed this 22 years ago when I wrote a paper for the WHO, because I predicted the chronic pain healthcare crisis. I was concerned about the financial unsustainability, because when you don't have enough money, we have this homeless problem that most medical system would just take care of them and they get into acute crisis. You give them some medicine, stabilize them, and then send them back out there. So we do not have a system approach, to healthcare, and we need, you young people who are very bright to think about, what you can, really try to spend the time to understand the intertwined factors in affecting what we have, and then, see what path would be the best for you. You can go through. I have some of the students who get into medical school and then get a JD because you want to get into health policy, and also getting a PhD and then get into health policy. And then some people get MD and MBA. Some people get doctor of public health. Some people are anthropologists and sociologists. But realistically, there's so many different ways that you can contribute to it. And I know there's all these crises that's overlapping, and I think that now with the inflation and the recession, it's going to be much worse. So I kind of see that the crisis is not looming; it's occurring to many of our citizens, not just our patients.
Very interesting. I also learned a lot. I just will answer this question from a different aspect, that when you start your medical school, you will be surprised how many topics in medicine has already not been discovered yet. There aren't therapies for many of the diagnoses. And also, it's not only the therapy that is missing so far, and is much more advanced treatments to be made in the future, but also the diagnosis sometimes cannot be made when the patient is still alive. So for example, in my field, we can unfortunately make the diagnosis of neurodegenerative diseases after a patient passes away. And we can only know what was the diagnosis of the patient who had dementia after the patient not alive anymore. And this is just one example that I'm dealing with, but I'm sure there are others in other fields of medicine, which needs much more research to be done in the future. So if some of you decide to do a research track, I think it's going to be a very rewarding, it's going to be a very long journey, longer than even just doing MD, but I'm sure it's going to be very rewarding.
All right. Thank you for listening to the panel portion. We're now going to be moving on to a Q&A via breakout rooms. And just a reminder that to please fill out the attendance form that was sent out in the chat earlier. So the breakout rooms are being opened right now, and then just choose a room with the doctor that you'd like to speak to and get to know more individually.
Oh, and if each doctor can enter their own rooms, that would be great as well. Thank you.
How do I know which one?
There's a function